local, and live. Covering Franklin and Washington counties, it's Let's Talk TriState.
Welcome to Let's Talk TriState, all powered by HomeRight Windows and Doors in Waynesboro, the right choice online at homerightwaynesboro.com. Today we are joined by one of our experts, our wonderful experts in his field, as we have so often here on Let's Talk TriState, Dr. Ali Mahdavi. Dr. Mahdavi is a gynecologic oncologist with Wellspan Health, and he is in Chambersburg. Online, wellspan.org/GYNONC. Doctor, how are you today? Good to see you.
Very well, thank you.
It's an honor to have you here with us on Let's Talk TriState today. Our topic today is going to be gynecologic oncology. You are very familiar with this, and I think that anytime anyone hears oncology, we know we're talking about types of cancers, forms of cancers. It's unfortunate to have to talk about those, but at the same time, we are so thankful that we have someone such as yourself, your team, your practice at Wellspan Health so easily accessible for us. So before we begin with the questions that I have for you regarding our topic today, let's talk about you. How did you get to where you are? What got you into medicine and then specifically gynecologic oncology?
So after I finished medical school, I became interested in women's health and specifically obstetrics and gynecology specialty. And I pursued formal training in OBGYN residency. And during my training, I was impressed with the impact of the gynecologic oncology specialty, helping women diagnosed with gynecologic cancers. GYN oncology is a specialty that combines advanced surgical techniques with novel treatments, and this combination was very appealing to me, and the fact that GYN oncologists or gynecologic oncologists provide comprehensive care to women with gynecologic cancers made me choose gynecologic oncology as my subspecialty.
Okay, very good. So what are the most common types of gynecologic cancers that you come across in your practice?
The most common gynecologic cancer in the United States is endometrial cancer or cancer of the uterus. Every year, about 70,000 women are diagnosed with endometrial cancer in the United States. Okay. And the main treatment for endometrial cancer is surgery. And in some cases, we need to give additional treatment, what we call it adjuvant treatment, after surgery, such as radiation or chemotherapy. The second most common gynecologic cancer in the United States is ovarian cancer. Okay. Every year, around 20,000 women are diagnosed with ovarian cancer. Unfortunately,
just to clarify, I'm sorry. So the endometrial cancer, 70,000 per year, and ovarian, 20,000.
That is correct.
Sorry, go ahead.
Unfortunately, most ovarian cancers present in more advanced stages. And in addition to very complex surgeries, most women with ovarian cancer need additional treatments such as chemotherapy or targeted therapies that we call them novel cancer treatments. Sure. The third most common gynecologic cancer in the United States is cervical cancer. About 12 to 13,000 women are diagnosed with cervical cancer each year in the United States. The treatment for cervical cancer is either surgical treatment or combination of radiation and chemotherapy, or chemotherapy with novel treatments. So there are a variety of treatments that we use to treat cervical cancer based on the stage and the presentation of the disease. Fortunately, the incidence of cervical cancer has significantly declined in the United States over the last few decades, and it's mostly due to availability of screening such as pap smear and spatial virus testing,
sure.
As well as vaccination.
Mm-hmm. Now, I want to backtrack, if I may. When it comes to the endometrial cancer, or any of the cancers, as a matter of fact, I know you said with ovarian cancer, typically when it's diagnosed, it is farther advanced than the others. How does endometrial cancer present? Is there a warning sign that is early? I think with any cancer, time is key. That's what we always hear is if catch it early, you have a better chance of beating it in the long run. So endometrial cancer, how does that present? Or is it something that you don't know until you get a particular test?
Fortunately, endometrial cancer presents in very early stages with abnormal bleeding.
Okay.
Most women with endometrial cancer have some kind of abnormal bleeding, either is bleeding after age of menopause, which is not normal in any circumstances, or women who are close to age of menopause and they have significant irregular bleeding.
Okay.
So this kind of symptoms and abnormal bleeding is a kind of blessing in disguise that directs the woman to think about something is not right. And for this reason, they usually present in earlier stage disease. Contrary to endometrial cancer, ovarian cancer, unfortunately, doesn't have early symptoms. So by the time the patient becomes symptomatic, has pain or bloating or bleeding or other symptoms, usually the disease has already progressed to more advanced disease.
Now, when you mentioned about abnormal bleeding after menopause, when a woman reaches menopause and shows with signs of one of these, or at least ovarian or endometrial cancer, is the typical course of action at that point a full hysterectomy given the age, or is it a preference, or is it based on how far along are we? Because I would assume, correct me if I'm wrong, that much like excising a tumor, if a cancerous tumor, is a best case scenario if you can get it all. If the only affected area is the lining or for endometrial or the ovaries, would the easiest and most get it all would be to do the hysterectomy?
Sure. So there are different treatment modalities, and hysterectomy is one of them. It depends on type of cancer. Treatment for endometrial cancer could be different from ovarian cancer or cervical cancer. And also it depends on the stage of the disease and the presentation. For example, most endometrial cancers present in early stage. So removing the uterus, or what we call it hysterectomy, and a procedure that we call it staging, sampling the lymph nodes, and removing the tubes and ovaries, in most cases is curative for endometrial cancer. In more advanced stages of endometrial cancer, because with surgery we can't get around the tumor completely, then we have to give additional treatment or other types of treatment before surgery or as the main treatment. Similarly, for ovarian cancer, in probably 50% of cases, we can proceed with surgery as the primary line of treatment. And these patients would require additional treatment either in a form of chemotherapy with or without other targeted therapies, or if the cancer presents in advanced stages, we may start with chemotherapy. In other words, the treatment would be surgery, chemotherapy, but the order of the disease, the order of the treatment, whether surgery comes first followed by chemotherapy, or chemotherapy comes first followed by surgery, depends on the stage of the disease.
What if any does the age of the patient have to do with the treatment? I believe, if I remember correctly, when it comes to the treatments of ovarian cancer, first of all, is it more rare in younger women?
Yes.
Okay.
The average age of ovarian cancer is about 60 to 65.
Okay.
So we see most ovarian cancer in women who are in age of menopause.
Okay.
There are very rare ovarian cancers that present at younger age, but in the majority of cases, you're right.
And this is just going to seem like one of those obvious questions. Is there a known cause or a known reason for that, why it presents later in life as opposed to so rarely in younger women?
Yes, and the main reason is that the ovarian cancer grows in the pelvis, and pelvis is a sort of roomy space.
Okay.
And the cancer can grow to a significant size in the pelvis before it becomes noticeable.
Okay.
The fact that growing inside the abdomen does not always cause bleeding, so there is no warning sign.
Understood.
By the time woman becomes symptomatic, usually it's a stage that the cancer has grown to a size that puts pressure on pelvic organs.
Okay, understood. Now, as with any cancer that we hear, prevention is key, prevention and time. Is there anything with these types of cancers that women can do to help prevent this? And if so, when should they do that?
Yes, there are measures that could prevent common gynecologic cancers. The most important is lifestyle and optimal body weight and balanced diet.
Okay.
Obesity is a major risk factor for endometrial cancer and ovarian cancer.
Okay.
So maintaining optimal body weight, diet, and physical activity, 30 minutes moderate physical activity a day would prevent obesity and also some of these cancers.
I think we've heard for years, and I myself can attest to it, I lost 140 pounds over the course of a year, and there's not one part of our physical body that I don't think that our weight touches. And if you're overweight, it can negatively affect almost every system in your body. To the opposite side of that, if you lose the weight, all of your systems are positively affected. And that just goes to show what you've just told us is the case with, and I would assume not just, and I'm not asking you to delve into this, but not just with these types of cancers, but with any types of maladies. That I'm sure that keeping and maintaining a proper body weight, nutrition, lifestyle, as you said, some exercise every day, I think gets us, at least equips us the best, wouldn't you say?
That is correct.
Yeah.
We know other cancers such as colon cancer, pancreas cancer, breast cancer, these are all also associated with excessive body fat
Right.
and overweight and being overweight and obese. Other risk factors could be infections such as human papillomavirus infection or HPV infection. The vast majority of cervical cancers are caused by HPV or human papillomavirus.
Okay.
So measures such as screening, pap smear, testing for HPV, and also HPV vaccination could significantly decrease the chance of cervical cancer.
Oh, okay.
For ovarian cancer, we know 15 to 20% of ovarian cancers have some genetic basis, or they are part of what we call it hereditary cancer syndromes.
Yeah.
For this reason, for any individual with diagnosis of ovarian cancer, we recommend genetic counseling and genetic testing to find out if the woman carries any of these genes, and if that's the case, the family could be tested. Mm-hmm. Similarly, if a woman has a strong family history of ovarian cancer or endometrial cancer, we strongly recommend genetic testing because some of the, as I mentioned, about 15% of ovarian cancers and up to 3 to 5% of endometrial cancers could have genetic basis.
Now, I think one of our often overlooked areas when it comes to this are the families themselves that are not physically suffering from these types of cancers or any types of cancers, but no less are in the fight with the patient. And not trying to certainly compare the two, I'm going through it is so horrendous, but When it comes to the families, what services or what options do you have for them to help guide the families through this as well, both before, during treatment, and then post-treatment?
So we routinely engage families in discussion of the diagnosis and treatment. And also in the phase that we call it surveillance, women who are cured from cancer, and we put them on surveillance to make sure that the cancer doesn't come back. Right. So I personally strongly encourage family involvement. And we work as a team. We have nurse navigators, we have genetic counselors, we have nurse practitioners, we have social workers, and we encourage the team to engage with the family and to explore the needs of the family. Sometimes it's some support, could be some social issues, could be some psychological issues. And this way, not only we engage family in the treatment, but we provide support for the family as needed.
I think anytime we hear the word cancer, whether it is early and very treatable, or whether it is advanced stages and its worst case scenario, just the word in and of itself is so, as it should be, stigmatized. Nobody wants to hear that word associated with their name. What I'm going to ask now is, have you found in a lot of cases that women who come out on the other side and have a good prognosis, that they often need therapy services for having just gone through what I'm sure is a traumatic, not just physical, but mental event?
That is correct. And I think that kind of support and engaging them with the support system. Sometimes we connect patients with similar patients who had the same experience and went through the whole process for them to know that they're not alone in their journey, and engaging the team in supporting the patient and what we call it survivorship, to follow these patients closely, not only for physical symptoms and physical changes, but for mental health is extremely important.
Yeah, there can also be that, oh my goodness, I survived this. Now I'm going to be, my mind is going to trick me into being afraid of doing anything, because now it becomes preservation. And I went through this, and now a friend of mine went through this, which is why I bring this up. And she came out on the other side with the good prognosis, but she just wasn't the same. And I've, her family, and I've said many times, perhaps you should seek counseling, and she's decided not to. But I think everyone around her notices the change, and we sympathize. We know why. We get why. But then again, all of us say, but we haven't gone through what she's gone through.
I completely agree with you, and for that reason we have to be very transparent with the patients about their prognosis and their expectations. And what I found is that the best mentor for patients are patients with the same diagnosis who went through the same experience, and they're back to their normal life, good quality of life, and they're very functional in the society, and they could demonstrate to the patients that they could get back to normal life.
I think too, to your point with that, it is very well said, is that we often say, and it doesn't matter cancer or anything, if we go through something and someone is trying to talk to us, we often can say, you don't understand. You don't know what I'm going through. So that's not an option when you're talking to someone who's been through it. They do know what you're going through. They've been there. They've seen the other side. They're there. Let them help you. I think that's wonderful. I believe you've already answered this question in what we've just covered in the last couple minutes, Dr. Mahdavi, but what sets your practice apart, in your opinion?
I try to provide, or my goal is to provide comprehensive care for the patient. It's not just the physical aspect of the cancer treatment. The emotional aspects, psychological aspect, family support, and the fact that we provide surgical services and systemic therapies such as chemotherapy and other targeted therapies in our practice, this allows the patient to get comprehensive care under one provider. That's one aspect. The second aspect is that I look at individual needs of the patients. Different patients may have different needs.
Yes.
And different perspective of their disease. So it's very important to be very upfront with the patient and engage them in the discussions and tailor the treatment to the desires and the best treatment that would work for that particular patient. My training and experience in surgical treatment and other treatments also I think is important. Experience matters. In addition to gynecologic cancer training, I did additional surgical training, including minimally invasive and robotic surgery training that allows me to tackle the surgical aspect of cancer treatment in the most efficient and most advanced ways.
Dr. Mahdavi, before I let you go, are there any, we always hear about advancements in treatments for any type, all types of issues regarding health. But when it comes to these types of cancers you've talked about today, are there anything that excites you when it comes to advancements in treatments?
We have made lots of progress in treating gynecologic cancers in the last 10 years. 10 years ago, some of the advanced ovarian cancers were thought to be terminal diseases with no definitive cure. We now use some novel treatments and targeted therapies that cure some of these women who in the past had no other options. One example would be immune therapy for cancer of the uterus.
Okay.
A group of patients show a molecular profile or type of cancer that are very sensitive to immune therapy. Based on my own experience, I've seen things that you could describe it as miracles in medicine. Not too long ago, I had a patient with advanced endometrial cancer, and the whole pelvis was involved with cancer. And after 3 courses of combination of chemotherapy and immune therapy, I could not see any disease on the cervix. Wow. And now the patient is a candidate for a surgery. Similarly, some of the ovarian cancer patients that used to recur within a year or 2 years of their treatments are in long remissions with a targeted therapy that affects cancer cells and spare normal cells.
Wow.
So these are very, I would say, targeted and specific treatment for cancer. And these women remain in remission for many years. Over the last 2 or 3 years, we have used what we call it antibody drug conjugates, which are basically packages of toxic drugs that are released only when they attach to the cancer cell.
Okay.
So we administer these medications, they circulate in the body. They do not release the toxic payload until they attach to the cancer cell. Wow. That way we deliver high dose of chemotherapy to cancer cells and spare normal cells from the side effects of this medication. Not only we provide very high dose toxic treatment to the cancer cell, we spare other cells from being affected. So
essentially a targeted attack.
That's exactly right.
Wow.
So we have seen all of these advances over the last few years, and as you mentioned, the word cancer is very scary to women, and many women present to us with the assumption that their disease is terminal or any cancer diagnosis is equal to death sentence. Yeah. And we have seen these significant improvements. And it's very exciting times to be in gynecology cancer field.
I completely agree. Well, Dr. Mahdavi, thank you so much for joining
Thank
us
you.
today on Let's Talk Tri-State. This is Dr. Ali Mahdavi. He is a gynecologic oncologist with Wellspan Health, online wellspan.org/GYNONC. Thank you so much for joining us today on Let's Talk Tri-State.
Let's talk Tri-State.
If you'd like to be featured on an upcoming episode of Let's Talk Tri-State, call 717-597-9200 or email letstalk@921thegoat.com.